Parotid.
What is the most common tumor in the parotid gland?
So most common tumor is benign tumor, sir.
Yeah, okay. Most common benign tumor is pleomorphic adenoma. Second is Warthin's. Okay.
Yes, sir.
So why females are more for this salivary gland tumors per se? Any other etiology is there? Forget about pleomorphic adenoma for the time being. Autoimmune disorders. Okay.
Yes, sir,
Autoimmune per se is more common in women. Okay. Now,
Yes.
religion per se here is nothing to do with your presentation. Okay.
Okay.
So I would have straight away put it as 48-year-old female, resident of whatever, teacher by profession, whatever you are written socioeconomic class, present to the hospital with the following complaints. Okay.
Yes, sir.
Yes. So that is fine. As I mentioned, next slide. Yes. Now this, just a minute. Bead size to grape to watermelon, orange era is over. Okay. So we have to move out of that. So it just, you can even tell, everyone knows a small means, when you say bead means say about, no harm. You don't have to describe it as a plum to orange to all that items. Okay. That's okay. It's a very small in size and gradually attain the size of a grape. Everyone knows, say about 1 to 2 cent. It is accepted.
Okay,
Now,
sir.
what is the importance of this pain other than parotitis?
Sir, pain can also be due to salivary gland obstruction by a stone, also due to the capsule.
1 minute, Ashik, that's fine. We are in the parotid, correct?
Yes, sir.
So I am only talking in terms of the tumors.
Okay.
Why this pain is important? Because one of the common presentations of malignant tumor is not necessarily facial nerve paralysis. It is with the pain. Okay. You should always keep that in mind. When any salivary gland tumor, patient present with the pain, you suspect malignancy. Okay. You have to keep that in mind. Yes, stricture, stenosis, stone. Remember the 3 S. Okay. Always. They do produce pain, but salivary calculus per se is least common in parotid. So the reasons are many. I think this is not the forum. So remember, easy: stricture, stone, stenosis. Okay, that is the one which produces pain. Few things have been already asked. Rapid increase. What is the difference between rapid increase and sudden increase?
Sudden increase
Yes.
within a day or something, sir.
So that typically does not happen in parotid. Already, Dr. Modi has already mentioned about it, right?
Yes, sir.
Sudden increase, sudden is common in thyroid due to hemorrhage. Okay. Hemorrhage.
Okay.
Rapid increase. Ashik, yes.
Rapidly seen in malignancy, sir.
Okay. So once it's all about the swelling first always. Your patient has present the swelling.
Yes, sir.
Onset, you have mentioned duration, progress. One important point, everyone talks about increase in the size. You need to ask decrease in the size.
Okay, sir.
Why you want to know the decrease in the size? Tell me. Yes.
Decrease.
Since you mentioned some patient says it sometimes decreases, sometimes increases. Typically, submandibular salivary gland, it happens.
Yes, sir. It is typically in if there is obstructed calculi.
So it's basically in parotid also there's an entity called as silectasis.
Sir.
Ectasia. What is ectasia means?
Ectasia is narrowing of the lumen.
No. Not stenosis. Ectasia. Bronchiectasis, silectasia. Heard of that terminology? There could have been a congenital manifestation. Okay. This is 48-year-old lady. not really required, but like typically they're more prone for infections, and little massage when infections settle down, it reduces in size. Okay. So that is associated with the increased salivation. You have written about other factors like, no difficulty in opening the mouth. In relation to this salivary gland tumors, what is the cause for difficulty in opening the mouth?
If the temporomandibular joint is involved by the tumor, there can be
One,
difficulty
TM
opening the
joint involvement, especially due to malignant tumors.
tumor, sir.
Now,
Second,
but one, why? Just thank you, correct. But one important thing you should know, this is the joint. Joint is a little above, but what is the muscle there deeper to it?
masseter muscle, sir.
Uh,
Can be a
so, so you should know when this question is asked, either it's
okay.
inflammatory. Whenever you have acute painful conditions, definitely there's trismus. TM joint involvement, yes. TM joint arthritis, yes. Similarly, masseter right? Yes.
Sir.
So now changes in the skin over the swelling. Yes, definitely you can get it. Not that it is rarely in very advanced diseases you do get. Yeah, can you go to the next slide, please?
No
Yeah.
history of fever, evening rise of temperature, night sets, loss of weight or appetite.
Just 1 minute. Just one. Hold on. I can read that. Why this suddenly you have brought this evening rise of temperature, night sweat, 2 words?
Sir, one thing is to rule out tuberculosis, and second is
See,
to rule out liver.
I'm not trying to say that it won't happen. Patient 4 years duration. We are talking our direction of thinking. See, all that examiners for you, whether it's a national board or the MS, the one important thing is what is your way of thinking? Okay. 4 years duration. Can it be anywhere in the body tuberculosis? You please don't think in that direction. So this word is not required because they will invite so many other questions. Why evening raise? Why night sweat? There'll be some differences. They're not required. Loss of appetite, loss of weight in parotid, thyroid, even for that matter, breast, even in malignancy, it is not common unless it spreads. Don't mention that word. No history of fever is accepted. Even here, 4 years duration, I will not ask, but you can't say you are wrong. Now, discharge from the swelling, is that in second infection? Is it common to get second infection in the parotid gland?
No, sir, it is very rare, sir.
Then why you ask that question here? What is the title of your talk? Title of your case?
Parotid region.
Parotid region. Very good. So tomorrow, somebody can come exactly like your case. Like your case. But it can be a simple sebaceous cyst in the parotid region. I appreciate that your title. You are not mentioned as a whatever diagnosis, but you are written as swelling in the parotid region. So obviously DD comes in that. So that's okay. Otherwise, parotid per se, thyroid per se, this is not a, because they are all enclosed by tough fascia. What is the fascia covering the parotid gland?
A deep cervical, investing layer of deep cervical fascia.
So parotidobasilic fascia. Yes, that's one of the splits and encloses. So thyroid also. So you will not get that kind of, too much to rupture outside and form sinus or, fungation, etc. Trauma, not important. Not important. Okay. What is the interest? Why do you ask? Is your swelling in other parts of the body? No. You should be specific. You should say other swellings in the neck. First, we'll talk about the neck. If this patient has multiple swelling in the neck, what do you suspect? First
Sir,
is unilateral, then is bilateral.
Yes, sir. If it is bilateral, we will suspect Warthin's lymphoma, sir.
No, don't please don't use the word Warthin's lymphoma. Okay, you are using that is not the correct word. Say Warthin's tumor. It has been called as not lymphoma. What is the full name of that?
Cystadenosal lymphomatosis.
So it is a misnomer. It is a misnomer. What I'm trying to tell is If there's a swelling in the parotid, unilateral swellings, think of malignancy,
Okay, sir.
lymph nodes. But I
Okay.
asked you, so what is important is nothing like any other parts of the body. Then in a post-graduation in surgery, nothing like very non-specific words. Patient does not complain of any other swellings in the neck on the same side or on the other side. If it is other side, it can be a multiple salivary gland itself. I
Yes,
think
sir.
that discussion came, Jogren syndrome and all that things, right? Yes.
Okay, sir.
Why this upper respiratory infection came suddenly here?
Sir, it is also mistake, sir. Thinking about measles, etc., I added.
No. Do
I
you
got
measles? No. Please. Don't get in the trouble in the exam. What is
yes,
relevant when you have a swelling? That basic things are there: duration, progress, regression, pain, then all that fungation, ulceration, bleeding, secondary changes. All that basic things you have to follow. Next slide,
okay.
please. So again, you have written so many things here. Depends upon in the university exam if this is a short case or a long case. Okay, short case means you are given about 15 minutes of time, and in the long case means you are given about. So depends upon the center, depends upon your examiners who select the case, depends upon what is expected from you. Without wasting much time on these issues, what does this overall things will tell you? All this dryness, closing eyes, deviation.
Sir, all related to facial nerve involvement, sir.
So that
Basically.
one word would have been enough. Okay, you are a postgraduate here. So because all this negative history, if there's a patient complains, one history is enough. Other don't have to go on telling all these things. Yes, you are written the swelling in the neck here, here. That should go there. Okay,
Understood, sir.
right? Now, among all these things,
Yes, sir.
don't have to go to breathlessness, cough, jaundice, abdominal pain, seizure. What do you have in mind?
Sir, these are actually metastatic symptoms, but I shouldn't have put it
There's no end for it, Ashik. There's no end. You could have written seizure, coma, and death also. What I'm trying to tell is, there's no. I don't know what books will give when you present the case like this. No, that is not the way.
there.
Complaints. Patient complains. You think patient complains of jaundice? Patient
No,
complains of
related to-
what is the relationship? Bony pain. See, we should not go too much beyond whatever is minimum thing expected. Okay.
understood.
Always any tumor, any including first is a loco-regional spread. If this patient complains of multiple neck swelling,
Hmm.
if you suspect lymph node, they may have the other things. So don't have to go to the level of breathlessness, cough, jaundice, abdominal pain, bone seizures. I know what you are meaning it, not that I don't know.
Okay.
Hepatomegaly, bony metastasis, seizures, coma. See, no, not required. Don't get into the trouble. Next,
Past history, sir.
anyone else wants to, sir, Dr. Modi, yeah. Should we continue?
Sir, I think
Okay,
you go
continue.
ahead because Dr.
Ah,
Modi will be
ah,
intermittently
yeah,
available.
please. Yes, sir. Please go ahead. Ashik, go ahead.
Okay, sir. Past history slide, sir.
Yeah, go ahead.
Okay, sir. Personal history, family history was mentioned, treatment history, and summary
One
of the
minute.
history.
So this needle test. So we are now we are in the, we are not in the world, we are across the 20th century. So you can straight away tell it's accepted at PG level and UG level.
Okay,
Okay.
sir.
Patient has undergone a fine needle aspiration cytology. You can straight away tell, don't
Okay, sir.
worry.
Okay,
Okay.
sir. Okay.
Needle test not required. And whatever, if the report is available, you should tell. Okay.
Okay.
If the report is available. Okay.
Okay.
Right. Proceed.
So this is summary
I'll
of
ask
me.
about this FNAC later. Yes, go
Okay.
ahead.
Summary of my history, sir. I already said painless, gradually progressive swelling below the
So
right
what is
ear.
that inference? What is that inference?
Sir, the swelling inference is that my patient has a parotid region
Okay, go
swelling.
ahead with the next slide. Next slide.
So these are my
Yes.
differential diagnosis, sir.
So yes, you are written nicely there. Yeah, parotid tumor, and obviously exam will ask you what is the most common parotid tumor. What is the most common parotid tumor?
It's benign tumors, sir, mostly pleomorphic adenoma, sir.
That's accepted. Even though it's a pathological diagnosis, it is accepted. Now,
Okay, sir.
enlarged lymph node, 4 years duration, less likely,
Okay, sir.
less likely. But if
Okay.
it is 1 year duration, 1 year
Okay.
duration, I have seen a size. What else can occur in this region? If it is due to enlarged lymph node, you can't give an enlarged lymph node. That can be some disease process, no?
Cold abscess
You
can
need
be
to
there.
have a disease. Cold abscess will never occur 1 year duration in that region. Okay. So it can
Then,
be a very, very low grade
okay, sir.
lymphoma. Okay.
Okay, sir.
Low grade. You
Mm,
have to know
mm.
indolent lymphomas. Not truly
Okay,
here, but parotid is also one of the sites of lymphoma.
okay, sir.
Parotitis should be ruled out
Okay,
unless
sir.
patient has a pain and autoimmune parotitis. Autoimmune parotitis can go on for a little longer duration, 2 years, 3 years, 4 years. But
Okay, sir.
but always remember there will be some
Mm,
amount of pain, discomfort, bilateral, etc. Yes,
okay.
other things are very well accepted. These are the swellings which can occur there. We discussed about that. Dermoid, lipoma, dermoid. What dermoid?
Sir, we can have epidermal dermoid, sir.
Sorry? What if the question is asked in front of the ear, what
Okay.
dermoid? Because you are written. Only I'm asking because you are written. It's a pre-auricular dermoid.
Auricular dermoid. Okay, sir.
Post-auricular dermoid. Why do they occur? These were the
Line of,
questions. Yes. Yes, Ashik.
sir, I'm not sure, sir.
That's because ear lobules, ear is formed by 6 tubercles. Six.
Okay.
If they
Okay.
fail to join or some go in front or back, a younger children, you consider that. Okay. Yes,
Yeah.
lipoma, sebaceous cyst, all these are possibilities. And well, lastly, another, if they ask you at this stage, other than the tumor, what else can occur in a parotid gland per se, which can go on for 4 years, 5 years like that.
Mm,
Parotid can also have lymphangioma.
okay, sir.
Parotid can also have hemangioma, vascular malformations.
Okay, sir.
Okay, like any
Yes.
other organ. So this is
Okay.
how you should think. Basically, we are thinking of a benign tumor or a
Mm,
benign swelling.
okay, sir.
In that, most common is pleomorphic adenoma. No signs of malignancy because you already mentioned no facial nerve paralysis, no
Yes.
pain, and no lymph nodes.
Yes, sir.
We are not thinking at this stage autoimmune because patient does not have pain, bilaterality, and other complaints.
Yes, sir.
The other benign swellings inside the parotid can be a lymphangioma, hemangioma, etc.
Okay.
And subcutaneous swelling, whatever you are given in the region, that is accepted. Okay?
Okay. Okay, sir.
Yes. Please go ahead.
Going to examination, I examined my patient in a well-lit room, sir, with proper informed consent in presence of a female attender bedside. She was cooperative, conscious, alert, and well-oriented, time, place, and person. Her general physical examination is mentioned. She has a BMI of 20.3.3. Hydration was well maintained, had a Karnofsky scale of 90. There was no pallor, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Her vitals, pulse rate is 86 per minute, right radial artery, normal volume and character, regular rhythm. There was no radial delay, radiofemoral delay. There was no vessel wall thickening palpable, and all pulses were palpable. All peripheral pulses were felt. BP was 110 by 80 millimeters of mercury in
Yeah,
the right.
as already mentioned, you should know if it's a short case for you, you should be able to quickly, come to relevant only. Otherwise, yes, This is what
Okay.
is expected from everyone, that as a general survey. Next, please go to the next slide.
Done examination. First, we had examination of the swelling, sir. We inspected the
Please
facial.
remember, just 1 minute.
Okay, sir.
Whatever we talk first is, we definitely know we are going to do the head and neck and abdomen also. We
Okay,
are
sir.
going to examine the spleen also in this patient. Whatever you say, as you see, start, you don't, you straight away proceed with the loco-regional examination. What is
Okay,
the
sir.
patient complaint? What
Swelling
is
in
the
the
patient's complaint?
parotid region, sir.
So you are not going to put it as a head and neck. Okay.
Okay.
You
Okay,
should
sir.
say, I will start with the loco-regional.
Okay. Okay, sir.
Local, regional.
Okay.
It will come automatically later. Okay, please go ahead.
Sir, on inspection, the facial symmetry was normal. A solitary oval-shaped grape-sized swelling in the right parotid region was seen. It was seen in the right preauricular region, extending up to the angle of the right mandible. It was displacing the ear lobule mildly upwards and outward, around 7 centimeters from the midline anteriorly, 2 centimeters from the mastoid posteriorly. It was limited by the zygomatic arch superiorly, and 2 centimeters from the angle of mandible inferiorly. The swelling is obliterating the groove between the ramus of the mandible and the mastoid process. The swelling is having well-defined margins in all the boundaries. The surface of the swelling appears smooth. The skin of the swelling appears normal. No sinuses or discharge were noted over the swelling. A needle puncture mark was noted. No engorged veins or visible pulsations were seen. No evidence of any swelling noted at the opposite side or in the neck. Coming to palpation, there was no localized temperature or tenderness. The swelling was palpable in the right parotid region, situated in front of and below the right ear lobule. It was 2 by 3 centimeter ovoid swelling, which is firm in consistency with limited mobility, non-fluctuant, and non-transluminant. The surface was smooth with well-defined regular margins. The posterior margin was 2 centimeter from the mastoid process. It was lifting the right ear lobule upwards. The inferior margin was 2 centimeter from the angle of mandible. Anterior margin is 7 centimeter from the midline, and superior margin is limited by the zygomatic arch. The swelling is not fixed to the overlying skin, underlying stretches or mandible. Overlying skin was normal and pinchable. There was no cervical lymphadenopathy palpable. Opposite to the face and parotid region was normal. This is my examination, sir.
Yeah, before you go to oral cavity, Dr. Mathur sir has raised a hand, sir. I think.
I just want to ask him, which grape
Yes, sir.
is the size of this swelling? I would
Yes,
like to
sir.
see. I would like to see which grape is the size, can we mimic the size of this swelling? This size, have you measured it on palpation?
Sir, it is 2 by 3
No,
centimeters.
it's 2 by 2.
2 by 3.
No, you have measured wrongly. From here, I can say that is wrong. Your one phalanx is 2.5 centimeter. Do you know that?
Yes, sir.
Huh? Yes
So,
or no?
Yes, sir.
Unless you have got a very short fingers. So,
correct,
see,
sir.
you don't try to, you should know what are the measurements like.
Okay, sir.
Okay,
I
Ashik.
haven't seen a grape of this size, unless it must be some in South American countries or somewhere. Like at least in Indian, I have not seen.
So, Ashik,
I have to
the
compare
point
with the
is
grape
here.
and all that thing. Yeah.
Yes. Yeah, point is well taken, sir. Sir, what Ashik, you should know that each
Okay.
person should
Okay.
know length of your index finger,
Okay,
you
sir.
know, because when you are doing a rectal examination, you know, so that you know on table also what is the length. You stretch your finger like this and say between the thumb and your little finger, stretch. So these
Okay.
are some of the things which are required. I just want to ask you, we'll come back to this here, that what do you call it this as, this second sentence, obliterating the groove between the ramus of the mandible and the mastoid process. What is that groove called as? It's an important,
Traumatic.
very good. So this is one of the characteristic features of the parotid swelling. Why it happens?
Uh,
Why it happens? It doesn't happen if there's a lymph nodal swelling or lipoma. You said no, lipoma, dermoid cyst, all that in front. That is because you know the anatomy.
yes, sir.
What is the extent of the parotid?
Sir, parotid superiorly it extends zygomatic arch, inferiorly to the angle of the mandible,
Yes.
posteriorly to the mastoid process, and anteriorly to the posterior border
So
of.
it almost goes that stylomastoid foramen. You remember that, no? So it goes behind the ear lobule. So that is why this is an important finding. Maybe in the another picture, it may be very clear here. I can't really make out the ear lobule. Doesn't matter. Oh, but upper limit. What is the upper limit?
Zygomatic arch, sir.
So what is it called as?
So curtain signs.
So that is important. Why it happens? Why curtain sign will happen?
This investing layer of deep cervical fascia, it splits into two and it fuses with the zygomatic arch, sir.
So
The
however
inferior-
big a parotid swelling, it won't cross.
zygomatic arch, inferior
Yes.
border.
So you have on inspection itself, there are many things to confirm
Confirm.
what you have a parotid swelling. This is how you start later, no? Later when they ask you why parotid, all these
Okay.
points should come into your picture. Location, then what is the extent? All that retromandibular groove is obliterated.
Yes, sir.
When you will not get a ear lobule raised in parotid swellings. What condition of the parotid? You will not get raise in the ear lobule. Simple question. It's simple. You are returning a lower extent. What is the lower extent generally? See here.
Angle.
So what you should tell? Does the parotid extend to the neck?
No, sir.
No, you are wrong. So you should know the inferior pole, inferior. Okay, it extends into the neck,
Yes.
mimicking a lymph nodal swelling. Okay, you know the levels, no? Level 2.
Yes, sir.
But node is deeper. Node is deeper to the deep cervical fascia. When you put a sternomastoid into contraction, the node becomes lesser prominent, but parotid becomes more prominent. You should know this point.
Okay,
So
sir.
what the point I want you to know is, if they ask you what parotid swelling, you will not get raise the ear lobule. One is the
Okay. Parotid
arising from the inferior lobe, inferior part. Second is some deep lobe. Okay. Third is peripheral. What do you mean by peripheral? Do you know the extent of the parotid gland? In front here. It has also got an accessory lobe. It almost goes in near the buccal region. Okay. So peripheral tumors, lobar tumors, deep lobar tumors, you will not get enlargement of the ear lobule. Okay. That is one of the points. If it is present, it will help you. Next slide. Yeah, this I think I have seen most of it. All that, that's what you see in inspection, that appears smooth borders around all that. Needle puncture should be replaced by the FNAC mark or something like that. What's the importance of the engorged veins?
Sir, involvement of the veins, sir. If the tumor is involving the veins,
Tumor is
retromandibular.
involving the vein. What do you mean by how the tumor is involving the vein? Which vein? The next question.
Sir, retromandibular veins.
The retromandibular vein, much deeper structure, the what you should answer expected. Any tumor, when you see prominent veins over the surface, where you are able to see, you should tell it's a more of a vascular tumor. All the vein is, all superficial veins have become stretched. Understand? Okay.
Understood, sir.
So most importantly, the tumor vascularity. And
sir.
also pulsation means, again, vascularity. Venous engorgement, venous obstruction, engorgement, pulsations. Okay. I think the rest is clear. Next.
Okay. Palpation it does.
Yeah, that I have seen. I just want to ask you one important thing which highlighted in dark. 2 centimeter oval swelling firm. What is this restricted mobility?
Sir, the fascia, it is within the parotid fascia, sir. So
So
we were
that is
able.
not called as restricted mobility. That's only the upper limit. My
Mhm.
question is, are you able to move this gland, move the gland
Mm.
vertical and horizontal? That's all.
Horizontal, it is able to
Ah.
move.
So, see, upper limit, everyone knows. Don't expect it to move like this. Yeah.
Okay, sir.
But what is most important is having written firm.
Okay, sir.
What do you understand by firm? Contents have to be solid or
So,
liquid.
solid, sir.
So when the solid is there, why these two here? That two are written bold. Don't do the splendor in the when you
Okay, sir.
write the theory, not theory, the clinical, case notes. Okay.
Understood, sir.
The fluctuation, transillumination to be done in basically cystic swellings.
Okay.
So to elicit the cystic means the consistency.
Okay.
You could have got this soft, fluctuant transillumination. That is the order.
Okay, sir.
To say it's when you feel sometimes it's soft, then you fluctuate, then you do transillumination. Then,
Understood.
of course, in the neck, you do later compressibility, etc. This is not today's this one. So what I'm
Okay.
trying to tell is Warden's tumor. You know,
Okay.
Warden's tumor consistency is what usually?
Sir, it is sold and cystic, sir.
Usually cystic.
Yes,
So
sir.
it's typically happens in upper part or lower part of the parotid?
In lower part, sir.
It's the lower part. So you should know bilateral lower part. That will be
Okay.
soft.
Okay,
That will may have cystic. That will be cystic.
okay,
There,
sir.
all these things will matter. Okay, surface is smooth, borders around, all that you are at. The next slide. So that's okay. Swelling. I hope you know that you have contracted the masseter. Okay.
Yes, sir. Yes, sir.
What happened to the swelling? Became more prominent or less prominent?
More prominent, sir. It is
So what
overlying
does
the
it tell you?
swelling is above the masseter muscles.
Not above. Say swelling is superficial. Okay.
Superficial.
Because when you say above means it means different.
Okay, sir.
Okay.
Understood.
Swelling is superficial or deep.
Okay,
Then
sir.
rest you have written opposite side of the face and parotid region here. Before that,
Okay, sir.
one important structures you should always examine in parotid before you go to oral cavity. That is the mandible and mastoid process. Angle of
Okay.
the mandible. Why is that?
Sorry, involvement of the angle of mandible.
No. Involvement of the angle of the mandible can be direct infiltration in malignancy, or
Okay.
what is the tumor which can spread by perineural?
Inward cystic, sir.
Yes. So you can have a bony resorption. So mastoid tenderness here, mastoid tenderness, mandible tenderness, all that has to be checked.
Okay.
Then only you say that. So inspection, palpation, all that consistency, mobility, fixity, plane of the swelling, you have written curtain sign. Then you mention about bony tenderness. Then you talk
Okay.
about this neck notes, whatever I can see here. Yes. Next.
And oral cavity, sir. Mouth opening was advocate. There was no medial displacement of tonsillar region. Parotid
Why
duct was.
you are looking why you are looking into this medial displacement?
Sir, if the deep lobe is involved, there can be pushing of the tonsillar pillar to one side. That
So what are
milling
those tumors generally called as? They are called as dumbbell tumors. Okay.
dumbbell. Okay, sir.
Because what happens is
Hmm.
there's one plane is called as, just like you have a fasciovenous plane of, what is that plane called as? Fasciovenous?
It is fasciovenous plane, sir.
Patty.
Patty. Okay.
Fasciovenous plane of Patty. Similarly, there's also called as one tunnel of Patty. Okay. Tunnel. You
Okay.
know the tunnel. So through which deep lobe passes and shifts and projects in the oral cavity. So that's a deep lobe. So the
Okay.
common question that is asked is, where do you look for parotid duct opening?
Sir, opposite the second molar teeth, sir.
Yeah, rest may not be great importance in your case. Tongue, base,
Okay.
oral cavity, deep lobe. What is this deep lobe? Where did you look for deep lobe?
So it's in bidigital, sir. On the tonsillar region I examined, sir.
Not exactly tonsillar. Yes, I know what you are. Very difficult to demonstrate here now, online classes. Between your styloid and the angle of the mandible, there you put your finger here and then inside. So
Okay.
that's how you look for the deep lobe. Okay. Yes. Next.
The temporal mandibular joint was examined, is normal. Opposite side of the parotid gland, including salivary glands, are examined normal. Bilateral submandibular subicular glands are also normal, sir.
Okay. Any other examination you have done?
Then I had examined for facial nerve, sir.
Yeah, I think yes, you can quickly say that facial nerve is a clinical exam normal. That's okay. Why did you look for all these things? What are the branches of the facial nerve you are looking here?
Sir, facial nerve has basically two main trunks, sir. Zygomatic-temporal and cervical trunk. Uh, and the zygomatic-temporal divides into temporal and zygomatic branches, and the lower trunk divides into buccal, which is upper buccal and lower buccal, then cervical and marginal mandible and cervical. So we wanted to examine each nerve separately.
I will ask you just one question to assess you. No deviation of the angle of the mouth. Which branch supplies? That
Angle of,
fourth, fourth point.
sir.
Which, see, this is what the exam,
Yes, sir.
you know,
Buccal.
the buccal is for what?
Buccal is
What
marginal
the test?
mandible.
Yeah, you're not written there, no? Blowing, etc. It's
Yes,
a
sir.
marginal mandibular. Okay.
Yes, sir. Okay.
All right. Then, yeah, this is what you written, drooling of saliva, overall asymmetry. Next.
Then spine, scalp, ear, nose, throat examination were normal. Systemic examination were grossly normal.
A spine scalp, generally what you have to see is the bony, that's
Okay,
a
sir.
typical thing. When we say scalp means, what is the scalp you are looking in that? Which layer?
Sir, Galia ponorotica layer.
No,
That.
no, no. Parotid is here and scalp, when you say spine is bone, correct? No, bone.
Okay.
Spine means bone, no? Correct?
Yes, sir.
Then in the scalp, which is the bone there, not Galia ponorotica.
Okay, bone.
P is what, man? P. P.
Sir,
Yes, forgot. 5 layers of the scalp, SCALP only. Ah,
pelicrane.
so bone met sucker there,
Okay, sir.
not in parotid. With the common thyroid is the common, breast is common, renal cell carcinoma, prostate. Okay,
Okay.
right.
Okay, sir.
Next, abdomen. What did you examine in the abdomen?
Sir, hepatosplenomegaly was examined, sir.
Just one or two questions. Why hepatomegaly? Why splenomegaly? Remember, your case is parotid.
Yes, sir.
Quick.
Sir, just metastatic.
No. See, remember parotid, very, for a long period, it is a local disease.
Okay.
Local infiltration, bone infiltration, mesenteric infiltration, etc. Don't expect to go to liver or spleen. Answer expected is simple. If this patient has got liver and spleen along with this salivary glands, it will go for a lymphoma, etc.
Understood.
If this patient has got only splenomegaly along with this, it will help you know diagnose of autoimmune disease.
Okay, sir.
Remember, women, salivary gland, spleen, and joint pain. Typical autoimmune. Okay?
Okay, sir.
Right?
Right, sir.
Yes. So, final diagnosis.
Sir, summary of my case. 48-year-old female with no comorbidities and past surgical history presented with a unilateral painless progressive increase in the right parotid region for 4 years. She had an oval-shaped swelling of 2 into 3 centimeters in the right
Yeah.
parotid region, firm in consistency, and not fixed to surrounding structures without any abnormality in deep parotid lobe, parotid duct, and facial nerve. So, my diagnosis is probably a benign parotid tumor.
And And today it's accepted after making a diagnosis of first is anatomical diagnosis. Anatomical diagnosis, parotid.
Okay, sir.
Then obviously pathology. We
Okay,
don't
sir.
say tumor of the stomach. We always straight away proceed. If there's a appetite loss, we say carcinoma stomach.
Okay.
We say carcinoma breast. We
Okay.
say fibroadenoma breast.
Okay.
Similarly, mostly 80% of them are pleomorphic. So you are justified 4-year duration to give.
Okay.
Yes, parotid tumor, mostly benign, and the most common form is.
Polymorphic adenomas.
Yeah.
Okay.
Any other diagnosis? Differential diagnosis?
No, sir.
So, yes, 4 years duration, you are justified, but a
Yes, sir.
little smooth surface, no? Smooth surface.
Okay.
What is the typical surface of a pleomorphic adenoma?
It will be nodular, sir.
It's a nodular, or even for a glandular substances, sometimes you hear the word lobulated surface.
Okay.
Even though you can't really pinpoint and say it's 1 centimeter, 0.5 centimeter, like that. Okay. So that typical. So this is a parotid swelling. We mostly think it's a solid tumor. Solid,
Yes, sir.
correct? Why
Yes, sir.
solid?
It is firm, sir.
Firm. Very good. So we are not thinking cyst. In the
Yes, sir.
solid, you have most common diagnosis is a pleomorphic adenoma. Then there can be so many pathological variants.
Yes,
So
sir.
many are there. Okay.
Yes, sir.
Let us not dissect that.
Okay.
Right.
Okay.
Anyone else wants to ask before then we go to the otherwise management? So what is the differential diagnosis other than the parotid swelling?
Sir, lymphoma can be a diagnosis, sir.
4 years, less likely, as I already mentioned, lipoma, neurofibroma, neurilemoma, all
Maybe
this thing can happen. Can parotid be the site of metastasis?
Sir,
You
I'm
know,
not.
when I say metastasis means spread, secondaries.
Okay.
Do you know the area where it drains to? Primary. If there's somebody comes with a parotid swelling of short duration, rapidly growing, and you suspect metastasis, do you know what are the primary area you have to look for? Primary.
Tonsil,
You should
sir.
remember the scalp.
Okay.
Scalp. Under
Okay.
the hair, there can be a melanoma. Okay.
Okay, sir.
Ashik, you are getting my point?
Understood, sir. Yes.
Yes. Scalp. And in an eyelid.
Hmm.
Eyelid.
Okay, sir.
So important areas, skin.
Okay.
Right. Yeah, go to the next.
Yes, sir. Can I go to investigation, sir?
Yeah, proceed.
Sir, in management, so these are my differential diagnosis.
Yeah, that I think let us not talk theory. I have already. Why not Martin's tumors? Quickly ask the question. Answer. Quickly tell the answer.
No cystic component, no bilaterality, mostly
Yeah.
associated
Never
males.
give a clinical diagnosis of oncocytoma. Okay. Then examiners will tell you know the FNAC findings.
Okay.
We have to talk about most common is pleomorphic.
Okay.
Common things are common.
Okay.
Uncommon things are uncommon. Rare things are rare.
Okay.
Clear? Wardens and these two accepted. Yes. Why not malignancy? Answer is very clear. Why not malignancy?
There was no rapid increase in size, no pain.
And
So
facial nerve.
was not there.
Lymph
Yes, sir.
nodes, etc. Yeah, non-parotid, everything. Yes, next.
Inflammatory non-parotid swellings were also
No.
ruled.
The management, because time is catching up.
Investigations, basic routine investigations were done. Then ultrasound, neck, ultrasound. So this is the investigation
Remember
what we
one
did in
thing in the 1 minute. 1 minute.
Yes, sir.
This is not the way. No. Next slide.
Okay, sir.
This is not theory class.
Okay, sir.
If you tell in the exam, PET scan, biopsy, all these things, it will be taken very seriously.
Okay, sir.
What you should tell? Initial examination is over.
Okay, sir.
Ultrasound.
Ultrasound was done to
Ultrasound.
confirm my diagnosis. Ultrasound, parotid region was done, sir. And
Yes. Go ahead.
Sir, and also ultrasound helps to know the organ of origin of the swelling, then size, shape, the consistency, and lymph node status. Also, it helps to get an FNAC from the specimen. So
What
ultrasound
I'm
is
trying to tell Ashik is that there's a difference between theory. In a theory
okay.
paper, when they ask you parotid tumor, yes, you can write, but definitely not you are written the PET scan if metastasis suspected or high-grade malignant tumors, including adenoid cystic carcinoma, even without metastasis. Issue is not about that. Issue is your answer in the exam is I'll do a ultrasound followed by ultrasound guided if possible an FNAC, and I'll wait for the report.
Okay.
If the
Understood.
report comes as pleomorphic adenoma, what will you do?
Yes, sir. If the
Then
report comes as
don't mention PET scan. Don't go in this way. This is clinicals.
okay,
Please try to understand. What do you do? Yeah, you
yes,
can
sir.
mention MRI, no issue about that, because it's a superficial lobe they have written. What is the advantage of the MRI over the CT scan?
Sir, of the CT scan, CT always helps to have more knowledge about the swelling, and if there is bony involvement, CT is good. But if there is neural involvement, we have to go with MRI, sir.
Excellent. It can have a clear interface between the tumor and the facial nerve. So what I'm trying to tell in the exam is your answer should be I'll do ultrasound guided FNAC. If the FNAC is pleomorphic adenoma, you are written in the clinical slide it is mobile, no lymph nodes, and your investigation will stop if a particular legal purposes, if they can afford, definitely nobody can tell you are wrong even if you mention MRI. Okay.
Okay, sir.
But if you suspect a deep lobe tumor, definitely you need both CT as well as MRI. If you suspect a facial nerve, definitely you need all the investigations. Is it clear to you?
Understood, sir.
Yes. Now, next, FNAC is pleomorphic adenoma. Just
sir.
show that Milan category. Milan.
Yes, I have it.
Yeah, that's latest. This one. There's so many new tumors also have been identified in that Milan. Earlier that were WHO. Now it's the Milan category. Yes. Next.
And management, sir. Surgical.
What do? You tell.
Sir, we will go for superficial parotidectomy, sir.
See, again, this is clinics. This is not seminar. Try to understand the difference between the seminar and the clinics. Answers should be very clear. I will do. Your answer should be, I will do superficial parotidectomy or what? Bailey and Lau latest edition talks about what? Not superficial parotidectomy. Little, this is a smaller one. My assessment of this, what is adequate parotidectomy.
Adequate, yes, sir.
It's also called as partial parotidectomy. But by and large, all the examiners will accept if you tell, I will do superficial parotidectomy.
Okay, sir.
Don't put this for this case.
Okay, sir.
In future, you should know case presentation is about your case.
Okay, sir.
Not talking theory. Total parotidectomy, neck dissection. What's the relevance here?
Understood, sir.
Nobody will ask you this. Nobody will ask you about Silogox, antibiotics. Okay. So your answer should be, I will do superficial parotidectomy.
Okay. Sir.
What do you understand by superficial parotidectomy? Common question.
Sir, we will give a skin incision after patient is positioned. And
No, I didn't ask you the steps. See, you should know in the exam. to answer what examiner asks you the question. If I ask you your name, you know it's very simple, Dr. Ashik Suresh Kumar. That's all. Similarly, when they ask you what is superficial parotidectomy, what should be your answer?
Yes, sir. The resection of the superficial lobe of the parotid gland.
That's all.
Yes,
Entire superficial lobe is removed, preserving
facial nerve
and the deep lobe.
Yes, sir.
Suppose if the deep lobe is involved, what is the treatment?
Then we'll go for total conservative parotidectomy, sir.
It is a total, because deep lobe you cannot remove without removing the superficial lobe.
Yes, sir.
Functionally, which is the maximum part, superficial or deep? Functional.
Superficial.
How much? How much? Any idea? How much? Suppose in a scale of 100, how much
80.
superficial lobe? 80 almost. So that's what is important here. Then the examiner will ask you, how do you identify the incision, and obviously Blair incision, flap raising, all that they may ask you. But common question is, how do you identify the facial nerve?
Sir. So we have 3 or 4 markers for facial nerve. We can have Conley's point. We can diagnose it from the Conley's pointer, sir, or the posterior belly of digastric we can trace back. We can also have the great auricular nerve, sir, and a stylomastoid foramen and styloid process.
Very good. So I think these are the standard questions. And how do you proceed with the parotidectomy, incision, and modified Blair incision, branches, all that you have prepared like a seminar, no problem. So how do you identify the facial nerve, etc., etc. Okay. So I just want to ask, sir, shall I? These are the theory part. I think you go ahead reading theory part. Supe sir, can I show some 1 or 2 slides which I have got?
Sure, sir. What you should
Yeah.
do, sir, if you have finished talking, you can show your slides and give general guidelines to students
Yes.
as well as give feedback to this particular student.
Correct.
What can be improved actually.
Yeah. Because, yes, Ashik, these are the theory part. I think all of you can always read about the divisions, branches, etc. In the clinical settings, how to, I'll just show you some slides. So I can only say that for the time being, can you unshare now?
Okay, I will unshare.
Yeah. I hope I'll be able to share. This is to help you so that if you are able to see the screen, say yes.
Yes, sir,
Yes,
I can
sir.
see it.
Yeah. So just the idea of showing this is for all of you, those who are watching, I'm just trying to enlarge it, but it's not happening. I hope it will go. Okay. Can you explain this surface, Dr. Ashik? Ashik?
Yes, sir. Hello.
Can you see my cursor there?
Yes, sir, I can see.
What's the surface?
Sir, it is lobulated surface. Sir.
This is typical nodular, and even such big ones are called a boscillation. Okay, right? Now look at the surface, nodular, and third person. You see actually it looks like it's a sternomastoid which has become prominent here. Okay, right. There's a little bit of going slow here. My computer or maybe hang or something. Doesn't matter. Can you? I'm trying to show you, but slides are not moving.
So just unshare and try it again. It might go away.
That's what, because I'll just say stop share. I'll share it again.
Share again, sir.
Yes. Yes. Only one, this slide is coming.
Okay.
Maybe sometime what happens is these are little big PowerPoint presentation. No problem.
Otherwise, what we can do, sir, you can go change the slide and again try to share. It might really work.
Okay, 1 minute. I just need some time.
No problem, sir. Take your time. We have enough time.
Hmm. This slide is shown.
Yes, sir. The same slide is seen.
I know, that is what I was just looking. After that, the cursor is not moving at all. Only this is coming because the presentation is a little bigger one. That may be the reason. Okay, it's not moving at all.
Yeah.
Maybe I have to take it, do some changes and all that thing.
No, sir. Do one thing.
Hmm.
Open it as a slideshow in your computer and then share.
Hmm. Okay, got the point.
Sir, I
Yes.
made you co-host, so I think it should be easier now. Just please try once more.
Yeah, I'm. See, this slide is visible, correct?
Now nothing is visible, sir. I think now it's getting visible.
Yeah, but this is showing at 4.
Yeah.
But after that, now it's coming, correct? Yeah, she has made me co-host.
Now it's coming, sir.
Yeah. So, Ashik,
Yes, sir.
yeah, can you just look at these 3 and comment? These are all my personal cases, sir. Just, yes. Tell Ashik.
So this swelling is lifting the ear lobule up, the first swelling. Second
Look at
swelling,
that. Look at that case which you have described, and this. See, that look itself says, some kind of a rapid growth male patient and all. What about this middle picture? Look at that middle picture.
sir, there is a surgical mark seen there, sir.
Yes,
Surgical
and
and I
and
can't,
and see the center.
sir.
See, it's a recurrence. Okay,
Sorry. Yes,
it's
sir.
a recurrence. Inadequate. They are not removed properly. It has recurred. Now, what about this lady here?
I can't see the slides, sir, now.
Huh?
Yeah, of course you can see.
Hey, third picture. Ashik,
Can't see, sir.
can't
Wait.
see.
Okay.
Can't see this picture. Three are there pictures. 3 pictures. No.
1 second.
See, man. You are using laptop or mobile?
I'm using laptop.
You can see here, madam.
Yes, sir, we can see all the 3 photos with the advanced
See,
elegance.
Ashik, in the third picture, we see a lady there, such a rapidly growing mucoepidermoid cancer. Okay.
Okay, sir.
With the thin veins over the surface. See there. So much vascular with the nodular bossulated surface. It is almost rock-like fixed. High grade mucoepidermoid cancer. This is a typical, lady with the pleomorphic adenoma. This, of course, is the picture to show you the hand.
Okay.
Can you see this picture now?
No, sir.
Are you seeing 6 pictures in this?
No, sir.
Yes, sir, we can see. I think.
I know I can
Ashik.
see.
Huh.
Yes, sir,
We
I
can
can
see.
see. So now you see in the first and second picture how nicely this is typical nodular bossulated surface, more than 2 centimeter nodules. And
Okay,
look
sir.
at that male patient below. This is the typical highly malignant parotid tumor, neglected case. Can you see
Yes,
this?
sir. Yes, sir.
And can you see a platysma like fold is lifted there? Just see the
Yes,
neck.
sir. Yes, sir.
That's called a platysma sign.
I think this is such a lovely collection. You see all the
Yes.
clinical signs so beautifully. Dr. Shenoy, a wonderful collection.
Yes, sir. Because this is over a period of time. That's a highly malignant tumor, adenoid cystic carcinoma, ulcerated in a subcutaneous plane and pulling this platysma here. Okay. These are all the
Understood.
classical. Okay.
Understood, sir.
Ashik,
Yes, sir. I'm seeing.
just look at that small video there. Okay, he's a male patient and a smoker. You can see that is a lower pole there. Actually, it was a Wardens. Okay,
Okay, sir.
right? So this is
Understood.
how the clinical features you should know, and that's one of the our patients with the CT as well as MRI. Okay, in the
Yes, sir.
MRI, use this word hyper intense like that. In the CT, you talk about the other things. Okay. Now, one more things, just want to quickly tell you, and then probably we'll wind up some of the preparations. Yeah, some of the important things you should know is these are the steps and facial nerve. Yeah, just have a look at that to your Blair incision here and see how the gland has been mobilized. And
Yes,
of course, these are edited videos. What happens is sometimes we may show it within 2-3 minutes, but it will take actually 2 hours. Okay. So
okay.
you should be, they will ask you this question because parotid has no capsule. Understand?
Yes, sir.
Parotid has got no capsule. What is it having? Pseudo capsule.
Okay.
Clear? Ashik,
Yes, sir. Clear.
thyroid has got a capsule. Parotid, no capsule. It's a pseudo capsule. So the pseudopodia of the pleomorphic adenoma. So the reason why pleomorphic adenoma recurs.
Yes, sir.
Okay.
Yes, sir.
One of the commonly asked question is whether the pleomorphic adenoma, if you just enucleate, recurs. Yes, one of the causes is because of the pseudopodia branches. Clear?
Okay. Yes,
Yeah.
sir. Clear.
Just I think now it's your facial nerve is being shown there. Just see that. Can you see that?
Yes,
I
sir.
don't know whether you'll be able to see it or not. That's how
Yes,
we
sir.
slowly dissect and remove this parotid gland. Okay. So then what else is there? Yeah, this is what is the actually nice case for a, extracapsular. Extracapsular means it is like a, you can also be mentioned, no? You need not remove the entire gland because small peripheral tumors you can always remove by using not superficial parotidectomy. Okay. Right? Yes. Sir, I think that's all from my side, sir.
Sure, sir. Yes, sir, I think you can give us feedback what he did well and how
Yes.
the points were
Okay. I'll just stop sharing now. I think I'm stuck.
So it's okay. I mean, you can just
Ashik,
Yes, sir.
can you hear me?
Yes, I can hear you, sir.
Yeah, your presentation is a good presentation, but always one important thing you should understand is that you should always talk about your patient, number one, not
Understood.
about other things. That is theory. Second, when you started presenting your slides, as I mentioned to you, you have to put the numbers. Okay, that's how you learn. Secondly, about your patient, I have mentioned. Thirdly,
sir.
few corrections we have done about the size and all that thing. And negative history, you don't have to go on telling so many no's, no's, no, 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 like that. Okay,
Understood.
right? Next, you are nicely written about those personal, family, and the examination is fine. Your examination of the inspection and palpation, and even there's nothing much to percuss there. There's no point in percussing this. Don't do it. Auscultation, yes, vascular, but not really required. But oral cavity examination, neck node examination, loco-regional. Don't straight away start and say, for a parotid swelling, I'll do head and neck examination.
Understood, sir.
Clear?
Understood. Clear, sir.
We are talking about loco-regional. Loco-regional. Your examination findings are mostly correct, but the one that should not happen, that if you say firm swelling, don't do that. So as a whole, otherwise you are done well. And when it comes to investigation and management, theory. Nobody is interested in the theory. Okay?
Okay. Yes.
Only to your case. What will you do? This is the questions.
Okay.
What will you do? Then don't say, when the deep lobe is involved, we do total parotid. No. What is your case?
Okay.
That is rest. What you have prepared is good for you to write the overall broad knowledge. Overall, you are done well. Still scope to improve. Okay?
Understood, sir.
Thank you. Thank you so much, sir, for
Sir.
such a wonderful taking of this particular case. And I think
Thank you so much, sir, for taking out time in your busy schedule on a weekday and joining us and helping the students.
Ashik, I have only one suggestion to you. As sir rightly said, no investigations. You should go little more. How would you go sequentially doing
Yes.
investigation? Not in one slide. You directly went to CBC and everything in one slide and you gave MRI report. I think it's important that you convey the thinking process. How do you really make a diagnosis and evaluate this patient for surgery? That is very important in the examination to convey. Okay, so
sir.
that's the only point where you need to really improve. And I think other points Dr. Shenoy has said very well. So Dr. Mathur, do you want to really say and conclude and then we close, sir?
No, I think Rakshana has conducted the whole thing very well, pointing out what should not be talked about and what should be talked about. See that laying emphasis on the right thing and completing the presentation in a short time, so there's more time for discussion. That's why I've written in the chat box also, too much irrelevant history. Okay,
Okay, sir.
negative history has no meaning.
Okay, sir.
Okay.
Okay, sir. I will improve, sir, from next
Yeah.
presentation.
And what differential diagnosis you cannot justify on the basis of the history and clinical examination, don't put that.
Okay, sir.
See,
Under.
like this was painless swelling, all right, and there was no history of fever or any other thing, and over 4 years' time, parotitis gets ruled out, isn't it?
Sure.
Yes.
Yes, sir.
So,
Understood.
yes, Ashik, it is like telling, no, if there's a mass in the right iliac fossa, in your exam case, you can't give 25 diagnoses because it is there in the book. Clear?
Yes, sir.
It
Yes,
has
sir.
to be related to your case. Is it clear? Right. That's all, sir.
Sure. Thank you, sir. This
Thank
will
you,
be,
sir.
this is for everyone.
Yes.
Since this time we have now included this into YouTube Live. Many people will be also seeing on YouTube Live, and this will be available on YouTube Live for others when you want to review it and again see it. So please spread it to your friends, those who have missed this wonderful class. And I must tell you, the Dr. Shenoy showed those cases and the way discussed is not so common. It's actually nice way you made everybody realize what are the kinds of signs and everything is there. So others want to see it in YouTube Live. It is available. And I think, Priya, you can share people the link of YouTube Live later on so that people can access. Okay?
Okay, sir. Okay. Thank you, sir.
Yes, sir.
Thank you, everybody.
Thank you, Mathur sir, Super sir, thank you, Shenoy sir.
Thank you.
So we conclude today's session. Thank you.
Very